Here is a challenging case of phacoemulsification in patient with narrow pupil. As we can see the pupil diameter around 3 mm. I started with 2.4 clear corneal incision. As it's clear, then I injected intracameral mydriatic agent, which is migraine. However, the pupil does not respond to the migraine. So I did viscodilatation using dispersive OVD. Then with the cystatome, I did the incision in the anterior capsule to initiate my capsular rhexis, which I'm planning to pass just behind the iris and the level of the pupil to optimize around 5 or 5.5 millimeter of the capsular rhexis. Then with the capsular rhexis forceps, I completed my rhexis. As we can see, the edge of the rhexis is not clear and it is behind the iris, and I think it's about 5 millimeter. Now empty the antechamber slightly from the viscoelastic. Then doing the hydrodissection, you can see I pushed the iris edge to see the edge and the rim of the capsular rhexis. Then you can see a beautiful posterior wave of the hydrodissection, followed by the hydrodelineation as it's clear. Look at the pupil. Now you can see the pupil is constricting. Here is the viscodissection and removing the cortex away from the nucleus. Then open the paracentesis using the MVR and rotate the nucleus to be sure it's free and your hydrodissection is complete. Here is the second paracentesis. Now it's the time of emulsification of this cataract through this small pupil. It's very important while emulsifying this cataract through the small pupil to be sure that your chopper is not over the rim. It should be passed very gently and slowly over and tangential with the nucleus at the equator to optimize your horizontal chop as it's clear. And also you can push the pupil edge with the chopper, as you can see while introducing your chopper to chopping this nucleus into small fragments. Then you can hold each fragment alone and emulsify it at the level of the pupil with the chopper helping in pushing the edge of the iris, as you can see, to hold the small fragments for emulsification. The reflection of the small pupil on cataract surgery, it is a real challenge because there is difficult in optimizing a well-centered, well-sized capsular rhexis. And doing the phacoemulsification through a small capsular rhexis and small pupil carries a high risk for complications like the posterior capsular rupture or anterior capsular rim tearing and extension into the posterior capsule and vitreous loss and dropping of the nucleus into the vitreous. Also, there is a high risk for the zonular weakness because there is more stress on the zonule while chopping this cataract through a small pupil. Also, there is a risk for zonular dialysis during the cortex removal while using the bimanual or coaxial irrigation aspiration probe. Here we can see I continued emulsifying. This is a nucleus at the level of the pupil, as we can see, was helping the chopper by pushing the edge of the pupil while holding this fragment. As it's clear now, hold the fragment and try to get it out the pupil and to the antechamber and complete the emulsification. Here is the time of cortex removal using the bimanual irrigation aspiration, also in the same way, as you can see, holding the cortex and try to peel it slowly at the center to be clear while aspiration of the cortex. And also you can use the irrigation probe to push the iris away to see the edge of the cortex to catch the cortex and clean it. Here is I shift to the other side port. On the same way, you can go and hold the cortex and try to peel it slowly to be clear at the center, then aspirate it. And also in the same way, you can push the iris with the irrigation probe to see the edge and try to clean all the cortex as it's clear. Then using the cohesive OVD to forming the antechamber and capsular bag to implant a single piece hydrophobic IOL inside the capsular bag as it's clear. Then adjusting the IOL slowly, and you should be sure that the IOL inside the capsular bag and the haptics inside the bag. Then washing out the viscoelastic anterior and behind the IOL as you can see. And finally, stromal hydration for the main incision and the paracentesis. And thank you for watching.